Two, one. Good evening. This is Dr. John Bennett, broadcasting from Miami, Florida. Tonight we have another in the series of Parkinson's Hangout educational videos. We have tonight here Dr. Abdul Rana, neurologist from Toronto, Canada, and noted Parkinson's educator. Last night we did Lewy body dementia and Parkinson's part 1. Tonight we're doing Lewy body dementia and Parkinson's part 2. Okay, good evening, Dr. Rana.
Good evening, Dr. Bennett. How are you this evening?
I'm fit as a fiddle. Okay, Dr. Rana, I'll start off with the questions. We did part 1 last night. Okay, what conditions can be confused with Lewy body dementia?
There are two main conditions which can be confused with the Lewy body dementia. One is Parkinson's dementia, or in some cases, early cognitive dysfunction of Parkinson's disease. And other main condition would be Alzheimer's disease. In case of Parkinson's disease dementia, it not only shares some clinical features with Lewy body dementia, but also shares some pathological features with the Lewy body dementia. So the diagnosis of Lewy body dementia and differentiating it from Parkinson's disease dementia could be a challenge in many cases. Mm-hmm. With respect to Alzheimer's disease, about 25 to 30% of Alzheimer's disease patients, they may have extrapyramidal motor features. And also, those individuals who have Lewy body dementia, on the other hand, they could show changes which are seen typically in Alzheimer's disease on postmortem examination. The Parkinson's motor features, psychotic visual hallucinations, cognitive fluctuations. These are the main features which would help the clinician to guide towards the diagnosis of Lewy body dementia, and they will help them to differentiate it from the Alzheimer's disease. The Lewy body dementia patients, they do better on recall, but they do worse on praxis as compared to Alzheimer's disease patients. Also, the anterograde memory loss is much less prominent in patients with Lewy body dementia as compared to patients with Alzheimer's disease. The Lewy body dementia patients also perform better in terms of immediate and delayed recall, as well as naming and recognition, as compared to Alzheimer's disease patients, whereas Alzheimer's dementia patients, they may be better in visual perception and verbal fluency. The early visual constructional dysfunction and visual impairment, which can be tested by copying figures, is seen more in Lewy body dementia, and that helps also to distinguish it from the patients with Alzheimer's dementia. The visuospatial deficits and the impairment of executive dysfunction, they are much less severe in patients with Alzheimer's disease when you compare them with Lewy body dementia patients. Some of the features, such as neuroleptic sensitivity, unexplained falls or syncope or delusions, or non-visual hallucinations, and RBD, they would be supportive of more Lewy body dementia over a diagnosis of Alzheimer's disease. The extrapyramidal features which we see in patients with Lewy body dementia, they could come on in case of Lewy body dementia much early on in the course of disease as compared to Alzheimer's disease, when they could come on, but they would be late in the course, and they would be less intense as compared to patients with Lewy body dementia. Also, the Lewy body dementia patients, they show more neuropsychiatric features, and they also show more intense attentional fluctuations and episodes of disorientation and confusion, which could change with the course of day as compared to Alzheimer's patients, who are relatively less prone to fluctuations as compared to Lewy body dementia.
How is Parkinson's dementia different from this condition?
The Lewy body dementia, some experts think, could be only diagnosed when patients have dementia, and that precedes either the onset of motor symptoms, or it would occur within the first year of the onset of the motor symptoms of Parkinson's disease. The Parkinson's disease patients, they have about 6-fold more likelihood of developing dementia as compared to healthy age-matched individuals who don't have Parkinson's disease. And the Parkinson's disease dementia would eventually develop in almost 80% of patients who have Parkinson's disease during the course of disease over about 10 years. So about 80% of patients in a duration of 10 years, if you follow them, they would develop Parkinson's disease dementia. Now, certain risk factors which are predictor of developing Parkinson's disease dementia in these patients are older age at the onset of motor symptoms and bilateral onset of Parkinson's symptom, they have more symmetrical onset. They have less of asymmetry of symptoms of Parkinson's on both sides, and also if they have declining response to levodopa as the course of disease progresses, that is also a risk factor. Also, the visual hallucinations and depression in the early stages in Parkinson's disease, that would be a risk factors for cognitive decline in these patients. Also, the patients who are cognitively normal and they have Parkinson's disease, they usually don't show those cognitive fluctuations. Patients with Parkinson's disease dementia, they do show a cognitive impairment, which is seen in patients with Lewy body dementia. Very close and very much similar and difficult to differentiate. So all patients with Parkinson's disease dementia, they would have motor Parkinsonian features, which may not be true in all cases of Lewy body dementia, although majority of them would have those features. The patients who show the Parkinsonian feature in case of Lewy body dementia is much less when you compare them to the patients who have mainly Parkinson's disease and they develop dementia. So Parkinsonian feature would be more prominent and more severe in that group of patients. Also, the extrapyramidal symptoms, they would be more prominent in this group of patients who has Parkinson's disease and they develop dementia rather as compared to the Lewy body dementia patients.
Are they different? These two dementias, do they look different on the MRI?
With respect to MRI, usually it does not help to a great deal that we can depend upon that, but about less than half of Lewy body dementia patients would show the preservation of the medial temporal lobes and hippocampus upon MRI. In the Lewy body dementia patient, the SPECT may show the occipital hypoperfusion, which is usually not seen in Alzheimer's patients, or most Alzheimer's patients at least. In both Lewy body dementia and Parkinson's dementia, there could be bilateral temporal and parietal hypoperfusion. So that may not help to differentiate these two.
Okay, how was the treatment of Lewy body dementia started or initiated?
The treatment of any dementia, first of all, is a comprehensive assessment which would need a detailed history, physical examination, in parallel history from a caregiver or a family member or a spouse is very important in these patients. So you also rule out the role of vascular risk factors or psychiatric conditions and any other effect of medications. And then education is the first step. You educate patients about the symptoms and treatment and then prognosis, and then how to expect or what to expect as the condition advances, and how to address those issues which would develop in day-to-day life of patients, and then also discussing the social aspects, social or medical legal aspects also, like patients should have a they should have their desires about their end of life plan and what they want to be the treatment like if they are not able to express their desires, and who is the power of attorney for financial as well as their medical decision making in future. So this should be discussed in detail with the patient as well as the family members. With respect to the pharmacological treatment, the cholinesterase inhibitors such as rivastigmine or Dunpazil, they are very helpful, and they would help with the drug-induced psychosis. And the use of neuroleptic drugs should be avoided in these patients, especially the typical neuroleptic drugs, as these patients are especially sensitive to them, and this could cause serious side effects. And in addition, it could lead to exacerbation of the motor features of Parkinson's disease, making them more slow and leading to postural instability and falls. The dopamine replacement therapy is also important in the Lewy body dementia-related Parkinsonism. So the dopamine replacement therapy has to be decided very carefully, because dopamine agonists are generally not the main choice of treatment in these patients, as they could make the psychosis and hallucinations worse. Also, other medications which we use in Parkinson's disease, such as amantadine, anticholinergic medications, they don't have much role either. So levodopa could be used in these patients, which would help to improve their motor symptoms, and the levodopa dosage would be lower as compared to Parkinson's disease patients, and the effect or response to levodopa would also be less as compared to in patients who have Parkinson's disease. And also, sometimes the hallucinations may be a problem in escalation of those or upward titration of these patients, because these patients do have postural instability, gait and balance issues, and dysarthria. So these symptoms could become worse with the dopaminergic medication. So one has to be very careful. Although they would help the rigidity, they would help bradykinesia and other motor abnormalities, would be helpful. With respect to the other medications, such as anti-muscarinic agents, which we use sometime in Parkinson's disease patients for bladder issues, or sometime for drooling or tremor, although they are used very rarely. So they should not be used in patients with Lewy body dementia, because they could again cause worsening of hallucination. The selective serotonin reuptake inhibitors, SSRIs, they could be a better alternative in these patients, and some reports have shown that low-dose quetiapine which you can start at a dose of 12.5 milligram and slowly increase it up to 50 milligram, they could provide a good relief of psychosis as well as behavioral issues in these patients. Another issue which is common in these patients is REM behavioral disorder. So REM behavioral disorder is more prevalent in patients with Lewy body dementia as compared to Parkinson's disease or as compared to Alzheimer's disease. And so in these patients, they may require a sleep study. Sometimes you may have to refer them to a sleep expert or a sleep clinic for further assessment and rule out any other abnormalities such as frontal lobe epilepsy or seizure disorder or other parasomnia. Once it is made sure that these patients have REM behavioral disorder, which is usually very clear from the history of patients, you can make a good part of judgment based on the history from the patient as well as spouse. The spouse history is more important as patient may not be aware of these changes. So you can use clonazepam as low as a 0.5 milligram at bedtime that could help the REM behavioral disorder in these patients. About half of Lewy body dementia patients may have severe side effects if they are exposed to neuroleptic medication, and one cannot predict which patients would develop the side effects before the drug administration, and these patients could develop into these patients could run into a major trouble, and these side effects are more common in patients with Lewy body dementia as compared to Parkinson's disease patients. So about half of patients may develop severe side effects as compared to Parkinson's disease patients, in which only maybe 1/4 of patients will develop such side effects. With respect to management of dysautonomias such as orthostatic hypotension or urogenital abnormalities as well as syncope, so same principles are applied, which could be used in other types of Parkinsonism, except that anticholinergic medications should be used with more caution. Medications such as oxybutyrine or chlorothalidine, which we use in patients with Parkinson's disease for bladder dysfunction, so they could make these patients worse. In addition to this tropsium hydrochloride, which does not cross the blood-brain barrier, could be a better choice in these patients. For confusion and hallucinations, these patients very often have psychotic episodes, and these psychotic episodes may lead them to go to a nursing home, and they could increase the burden of the caregiver. So these patients should be assessed thoroughly for UTI, pneumonia, electrolyte abnormalities, and also simplifying their polypharmacy. If they are on multiple medications, so trying to simplify that could also help with the hallucinations as well as psychosis. And if these patients are on multiple Parkinson's disease medication, then these patients should be assessed, and anticholinergic medications could be stopped first, and then one can stop if they are on amantadine. So amantadine can be stopped, and then selegiline, razagiline, or entacapone can be stopped. And if they are on dopamine agonist, then dopamine agonist can be lowered or stopped. And if you go through that stepwise approach, their confusion, hallucination, and cognitive fluctuations would improve. And if still they are not significantly improved, then the dose of levodopa, or first maybe the bedtime dose of levodopa could be stopped or reduced, and then the daytime dose of levodopa could be adjusted. However, one should make sure that they don't become too slow, that they are not able to move. So that should be taken into consideration as well. With respect to the newer atypical antipsychotics such as clozapine and quetiapine. They are quite helpful in these patients. Clozapine is much more effective as compared to quetiapine, but with respect to clozapine, they have to be in a blood monitoring program through a hospital because it can cause granulocytosis. So they have to have a periodic CBC monitoring to avoid granulocytosis, which can be a serious side effect of clozapine. And clozapine could also cause the side effects such as drooling, excessive sedation, and hypotension. In most of the situations, you can be okay by using a low dose of quetiapine. As I said, the clozapine is effective for the tremor as well. If patients have the tremor, so clozapine would be able to reduce the tremor. And sometimes you may need a bit higher doses of quetiapine, such as up to 100 milligrams, may be required. Most of these patients in most clinical settings, they would respond to quetiapine. Even low-dose quetiapine would be sufficient in many cases.
Okay, what are the practical steps in management of these patients?
When you see these patients initially, I think detailed history and a physical examination, any precipitating factors such as UTI, pneumonia, ruling out the medications which can increase these problems, such as anticholinergics, or if these patients are on sedatives and anxiolytics, so they should be stopped or they should be reduced significantly. Because sedatives and anxiolytics taken at bedtime, they could have a long-lasting effect, and patients could go through the fluctuations because of that. And if they are on multiple Parkinson disease medications, then stepwise, first anticholinergic medication should be stopped, and these patients should be reassessed. If they still are facing problem, then amantadine can be stopped slowly. This should be done gradually over a very low period, maybe lowering one dose every 3 to 7 days. And then after amantadine is stopped, if these symptoms don't resolve, then if these patients are on monoamine B oxidase inhibitors such as salicyline or azegeline, then those could be stopped. And then if these patients are on dopamine agonist and after going through these steps, they don't improve, then dopamine agonists could be either withdrawn or they could be reduced. In most cases, you may have to stop dopamine agonists for these patients. Now, at the end, they would be left on levodopa, and if they could be on entacapone, or sometimes they may not be on entacapone. If they are on entacapone, then you may have to reduce entacapone, or you may review the history and see if they are more confused in the evenings. First, you may drop the dose of entacapone in the evenings and see if that will work. If that does not, then you may have to stop all doses of entacapone. These patients sometimes could be up to 4 to 6 doses of levodopa with entacapone, or even more in some cases. So when entacapone is also stopped, most of patients will improve. And if they don't improve, then the dose of levodopa can be adjusted. It is usually not possible in most cases to stop levodopa, because these patients do need a baseline dopamine replacement therapy. If these patients still are bothered by these issues, then bedtime dose of levodopa can be lowered. And still, if they need help, then next step would be going to the newer atypical antipsychotics. First, I think clozapine can be tried at a dose of 12.5, and it can be slowly titrated. If you go up to 100 or 200, and still the patients are not able to manage because of these cognitive and hallucination issues, then these patients may need addition of either rivastigmine to see if they would respond. And rivastigmine is available in a patch also. So you can slowly increase it. If you want to give oral, you can start with 1.5 milligram once a day, which can be titrated upward, sometime up to 6 milligram twice a day. And if you start on a patch, then patch they can be started in patch number 5, which can be increased to patch number 10. If still they are not able to manage, then clozapine would be a better choice. And with respect to clozapine, there is about 2 to 3% risk of agranulocytosis, and a dose of 50 milligram or even less is usually safe and effective, and it would reduce the tremor of Parkinson's disease as well.
Very good. Do any non-pharmacological strategies exist in the treatment of Lewy body dementia?
That is a very important question, and I think that step goes with the pharmacological treatment. So when you are going through these changes, like lowering the medications and then discontinuing anticholinergics, amantadine, selegiline, so as you are doing those steps, so along with this or even before this, you should make sure their nutrition and fluid intake is adequate. Repeated orientation is very helpful. Having a clock in front of patient's bed, and the window should be kept open so that there is light and they know that this is the daytime and this is the evening time. Sometimes patients have more than one caregivers and they take shifts, so patients get confused. So orienting them, and light should be enough in the house nighttime when patients are sleeping. So it should be made sure that the principles of sleep hygiene are followed so that their sleep is uninterrupted and they get a good sleep at night. If they wake up at night time and they're confused, the light should be turned on, the caregiver should be available, and if they have to go to washroom, they should be accompanied. They should always use a walker at night time because that is the time where these patients can fall, and if they have hallucinations actively at night time or even any time in the day, the caregiver could explain gently, but arguing is not usually useful. It makes patients even more agitated. At the same time, the caregiver should not reinforce the hallucinations of the patients either. Also, the precipitating factors such as infection, dehydration, pneumonia, UTIs, or sometimes trouble with the vision if they have macular degeneration or the visual acuity is so low or hearing is less. So these things should be taken into consideration and addressed as much as possible.
Very good. Okay, that wraps it up for part 2, Lewy body dementia. Anything to say before we wrap up, Doc?
The management of these patients is not an easy task, and it could be a challenge. It could be a challenge for the caregiver as well as for the physician. Sometimes caregivers may feel quite helpless because these patients are quite difficult to manage. So the caregiver has to be patient. They have to learn the strategies to deal with the difficulties the patient is going through. They should have a very good communication with the physician. The physician should be available so that any changes in the status of patient or any urgent issues may be conveyed to them. And safety of patient is also very important because these patients are at a much higher risk of falls. They are much higher risk of nighttime injury, like when they have RBD, REM behavioral disorder, and they are enacting on their brains. They are flailing their limbs and crashing in bed, and some patients may try to get up and come out of the bed, sleepwalking. So these things are very common in these patients. So if there's a furniture, it should be made sure that they don't get injured. If there's a window close to bed, so that should be made sure they don't fall out of the bed or fall through the window. These things are very important, and these patients should be attended, And even the bathroom safety is very important in these patients, because orthostatic hypotension is quite common in these patients. When they finish having bowel movement or urinating, that is the time when they get up and they feel lightheaded, they fall down. And if they lock the door from inside, the caregiver may not even know if they have fallen. And washrooms are quite tight spaces. They have a lot of corners with the sink or with the commode and the walls in the towel stands, so they could hit their head and they could fall, and this may not be picked up unless the caregiver goes to the washroom and finds them on the floor. So safety becomes a very important issue in these patients. So fall prevention, repeated orientation, and not leaving them unattended is very important.
Very good, Dr. Rana. Okay, that wraps it up for Lewy body dementia and Parkinson's Part 2. All these videos can be seen on the Parkinsonism.tv channel. Thank you, Dr. Rana.
Thank you, Dr. Bennett.
And tomorrow night we'll continue with another one in the series of Parkinsonism education.
Sure.
Good night, Dr. Rana.